Hello and welcome to the AHF podcast. I'm your host, Joe Schwab. Before I bring my guest in, a quick word for anyone who's new here on what Operation FUBAR really is. We all know the old military slang FUBAR, F'd up beyond all recognition, use whatever version of F you would like. Well, the whole point is this. We set the highlight reel aside and we talk about cases that go sideways. The complication, the salvage, the operation that just didn't go to plan, because every surgeon has them. But almost nobody's willing to put one on stage, and in my experience, those are the cases that we learn the most from. So the deal is simple. We put a real case or multiple cases on the table, walk through how it came apart, and talk honestly about what we'd do differently. And I couldn't have picked a better person to do that with. My guest today is someone I've known for years through the Anterior Hip Foundation, and someone I'm genuinely lucky to call a friend, Dr. Nick Mast. Nick is a hip and pelvis surgeon in private practice in San Francisco, with about as serious a pedigree as the field has. He trained under Joel Matta from 2007 to 2008 at the Hip and Pelvis Institute, where he did probably well over 100 anterior approach hips before most of us had even heard the term. Then he went to Europe for his hip preservation training with surgical giants. He's also a second-generation surgeon, son of Jeff Mast, a true pioneer in fracture and reconstruction surgery. And these days, his practice runs heavy on complex trauma, revision, non-unions, malunions, the cases other people might send away, which, for this conversation, is exactly the resume you want. Nick, welcome to Operation FUBAR.
Thanks, Joe. And I really want to thank you. That was a very nice intro. Um, I, my father used to joke about excellent surgeons and excellent skill in the OR comes from lots of experience, and lots of experience comes from, some bad judgment here and there. So I guess this is the perfect opportunity to kind of talk about challenges. And so I'm glad you're putting this little talk together.
No, that's I really appreciate it, and I see no reason why we can't just dive right in.
I pulled together a lot of cases here that, while not all of them went, horribly wrong or had challenges, they definitely presented some unique stuff that I had to think about beforehand. And so we'll just dive right in with the first one here. So, we start off with some of the more straightforward problems, and we'll get more complex as we go. But this was a 69-year-old female. She had a remote healed both column acetabular fracture. It was over 35 years ago. And Joel and I looked at this case, over the years. We've seen I presented this case a few times, and whether it's secondary surgical congruence or whether it was a transverse T, I'm not sure. But what you can see here is you can see that there was disruptions of both columns. So there's a both column acetabular fracture with a residual protrusio deformity. And the challenge with the protrusio deformities is typically the trochanter is sucked up against the lateral ilium, and it can make mobilization very difficult. And other things that I think, we ought to be very cognizant of in this modern age is a lot of the AI driven imaging that we use during the course of the case to tell you about leg length, offset, and cup position are going to be largely useless because they're going to be relying on things like the trans teardrop line or the transischial line. And these things are obviously distorted here. You can see that the teardrop has been moved proximally, that the remaining ilium that's intact is actually the lateral portion that's in contact with the neck, as opposed to the, typical roof that you would typically note. So really the only thing that we have as a really static reference is the SI joints. And so that's kind of what I used here. So you can see when we do a,
By the way, Nick, am I right in thinking that she was treated conservatively at the time? It doesn't look like there was previous
Correct.
hardware in place that's been removed.
She was treated in traction for I think a few months. And then, yeah, this is what her residual was, and she left it for 35 years. And actually, interestingly, she went on to become a yoga instructor as a means of maintaining whatever motion she could and keep her functionality. So this is her life. She didn't have much motion of that left hip, obviously, but she managed to deal with it in as best she could. Um, yeah. So anyway, you could, as part of any sort of complex acetabular deformity, I either get a CT scan or Judet films. These are the Judet films. Judet, obviously this is the iliac oblique. And for those who are joint trained who may not be trauma trained, this is a great way of assessing the posterior column. You can see that the posterior column is intact, healed, but it's malunited. And here's the anterior column. And again, you can see the anterior column is healed, but again, malunited. And so this was enough for me to know that, we've got intact bone stock, intact columns, enough to put an acetabular component in, but we have some problems of where to put it. And so the surgical strategy here is like the same as I would do with any other cases. One, you want to restore the hip center. And then if you build out the femur correctly, you'll match the leg length and offset. So in this case, that was sort of the plan. And in order to get um, exposure correctly, I do a few little tricks. One is I do my neck osteotomy under fluoro. So that helps me guide where I am because the anatomy is distorted. And so being able to, use x-ray is just a great tool to make sure that you're starting the case off correctly. And then intraoperatively, I use the SI joint as a reference for leg length and offset as opposed to the ischium or the teardrop. And then another adjunct of the anterior approach is be able to place your screws under fluoro because, again, anatomy is distorted. Who knows if you're going to put the screw into the pelvis or into the sciatic notch inadvertently. So being able to do that under direct fluoroscopic control is really helpful. So, intra-op, it's proceeds in the usual fashion. We're reaming like we normally would. I use a slightly larger cup when we're doing a protrusio. And again, we're trying to lateralize that hip center. So you can do a lot of little tricks. You could use a rim fit and back fill graft. In this case, I just went with a little bit of a jumbo cup technique and got it in place, put my screws in under fluoro. And you can see here that I did a pretty good job of getting our length correct, but we're still deficient in offset. But I was able to make up that offset, or at least the global offset, by increasing to a high offset stem. And in that scenario, you're improving the abductor lever arm, which isn't bad. The center rotation has gone medial, so actually, this can result in a pretty functional hip, and that's what we got out of this case. And so, again, this case demonstrates, the typical landmarks that you normally would use. You got to make some considerations. You might have a little bit more of an offset stem available if you aren't able to fully reestablish your global offset. And, I think if that term is new to you when I'm talking about global or total offset, I would revisit. There's some great lectures through the AHF on, what offset means. I think Joel's talked about it numerous times on I think on this podcast, if not on some others, where we talk about the offset as it relates to the anatomic offset or the femoral offset, which is the center rotation to the anatomic axis versus the global offset, which is sort of the relationship of the femur to the pelvis. This is something that, this technique that I show next, I have to give great credit to a guy named Frédéric Laude, who the first time I saw this just blew my mind because I had come from a different school of thought on this, and he changed how I thought about it. And this has been sort of for me a workhorse technique for getting hip center correct. And so this was a patient with, Crowe II dysplasia bilaterally. And so if you can see this, he has a unique pattern of wear. So this is not may or may not be dysplasia, might have started off as dysplasia, but what we're seeing now is his profound arthritis has worn the bone away in a pattern that is very much like a very severe dysplasia. So it's created a big defect in the ilium above above the true acetabulum, and this is, the head wants to fall into it. And so when we're doing these kind of cases, again, the surgical strategy is to put the hip center correct and then rebuild the femur the way it's supposed to be. But, if you do that in a unilateral setting, and we got a bilateral disease, what we're gonna end up with is a leg length inequality. So something I learned from Joel was a simultaneous bilateral procedure. And this becomes then a simultaneous bilateral procedure with a goal of, again, fixing the hip center correctly. And there's a bunch of different strategies out there. There are augments, things like that, where people advocate. In my hands, when we're doing a primary hip replacement, one of our best sources of structural support is actually the native femoral head as it comes out. It can be uh, used well as a graft. So templating, this is my plan. I could recognize that by putting the hip center correct, I'm going to end up with a big defect above the acetabular component. And this is my strategy, as I talked about, and introp. So we'd take our fluoro spots during the course of the case. You can see that literally the screw is going through the cup right at the point where the the roof sort of departs. And so without appropriately addressing that, you can see that this cup would very easily on weight bearing fall into the defect above the cup. And you can see this best on the iliac oblique. You can see the defect here. Okay. So go ahead.
Is it you have that first fluoro shot with the cup in with no screw? I'm assuming that that cup was reasonably stable, at least at that moment, between the anterior and posterior columns as you were putting that in. Is that correct? Is that a correct assumption on my part, or was this cup more mobile than I would give it credit for?
You're exactly right. And I think this technique emerged largely, this sort of reverse grafting technique, which you're going to learn about, emerged largely with the advent of the newer generation high friction coatings that we've seen in the marketplace. Because early on, I think, the old poro coats and other things like that, you would have tried this technique and you would have had an unstable cup. It wouldn't have stuck at all. And you'd be really working to get this right. But the newer higher friction coating, which I believe this was a Gription cup from Depew, but there are a bunch of them out there. And the nice thing is you can get that early provisional stability between the columns. But this is also, I've seen this as a downside for these new components because people will commonly assume they have a stable component until the patient starts walking on it, and then it'll fall into the position where you would expect. So you get the false sense of security sometimes. So really, I rely on the radiograph, and Joel and I talk about this because he helped me out in the last when we gave a lecture on this. Is that kind of look at it like a lateral center edge angle. So where the roof departs from the cup, if you got about 20 degrees, well, then you're probably going to be okay. But if it ends up being like zero, like in this case, you probably ought to do something to add structural support. So, yeah, so in this case, a little graft goes right in there, and that's what it looks like, and it's fixed with a single 3.5 fully threaded cortical screw. And since it's a bilateral case, we do this on both sides, and the patient's weight bearing is tolerated out the door the next day. So it ends up being a really, fun case to do, and get to be artsy and get the angles correct of your screws and make it pretty. I love fluoro for that.
And nothing wasted, right? You get to reuse
And
femoral
nothing
head.
wasted. Yes, yes. Yeah, so in San Francisco, we got the, reduce, reuse, and recycle moniker for everything. And so here it is, reduce, reuse, and recycle in San Francisco. So here's how it looks if you want to see it on a sawbone so you can really understand it. I mean, this is the surgical strategy, and this is how I employ it every time now, is that the head you can see here is sitting in the false acetabulum. So you make your neck cut, you remove the head, and you immediately caliper the size of that head, and you go right back in with the same size reamer. Now you put that reamer right back into that false acetabulum. But again, you're not reaming into the false acetabulum, you're using it to decorticate, using it to get to the punctate, what we call paprika sign, right? Where there's little punctate bleeding in the bone. So you're just hitting that sclerotic bone just enough because you're preparing the bed for a graft. If you go too deep, you're going to create more of a defect and you're going to have a larger graft. Plus, you're going to lose some of the structural support of the sclerotic bone there. So all you're really trying to do with this first reamer is you're trying to just prepare the host bed. Then you just take that same reamer and then you redirect it medially. Okay. And that's how you get between the columns. Now you will upsize that reamer a few millimeters until you get that good columnar fit. And then you put your shell in. But you can see that big defect up there. So usually you can put your graft in at this point. But if you do that, the risk is as you tamp that graft in, you're going to pop your cup out. So what you do is you put at least one screw in provisionally and just One of the things I will caution you is that big screw that I put in, you got to be careful about tightening that thing all the way down because as you tighten it down, it will shift your cup. So usually I will tighten it almost all the way down, just sort of hold that cup in place while I put my graft in. And then at the very end, I'll tighten everything down really well. So we get our provisional fixation between these two columns. Then I take the femoral head, and this is a little foam diagram of what the femoral head looks like. I draw the hemisphere on it. And then depending on if we go back here, we can see from pretty much where those arrows are, I got to do an entire hemisphere of that graft. So what we do is we draw it all the way out. And then I draw a second line uh, that demonstrates the thickness of that. And if you cut towards the center of rotation of the ball, you'll end up with a graft that generally fits right into that hole. And so that's been the technique. It's usually pretty quick for me. It takes about 10 minutes extra on the case. And the only tools necessary is a small frag set, which pretty much every center has. So,
And do you tamp that graft in place before
yeah,
you?
that's kind of the technique. Yeah, so the older techniques, which was described for this, was you put this, graft in, and they put a bunch of screws and then ream into the graft. And the problem with that is that commonly you're testing your fixation when you're reaming. I don't know how many times I've done that older technique, and I've spun my graft right out of the acetabulum once the reamer engages it. So it's like this technique, you kind of put everything in first and then you tamp that graft in. And what I found in my own practice, having done now over 20 of these, is that we get very little graft resorption. And I believe it's because we are tamping that graft in so it's loaded before we put our screws in. And by doing that, I think it's more likely to incorporate than the older technique, which sometimes, you would shift that graft and it might not be in a position of loading and you might not perceive that you're loading that graft. So it resorbs over time.
Hmm.
So
Interesting.
so this is a solution, and a bunch of people out there are starting to show some really nice cases using this technique. But I think they all go back to the one of the grand masters of anterior hip, which is Frédéric Laude in Paris, who originally showed me this technique back in it was 2009, I think. So so this is a high hip dislocation. So a lot of the same techniques again apply here. Again, trying to get the hip center correct, um, and then sort of restore everything based on that. And um, so the challenge with high hip dislocations, Crowe IV, is they come in all. There's a big spectrum. I mean, the ones that are easier, in my opinion, are the ones that are more flexible. So when you do your clinical exam on these patients, the patient that has a lot of range of motion, an arthritic hip, but a lot of range of motion. I'll show you this X-ray, for example. Um, this left hip in this AP radiograph, the left hip was actually quite mobile. The right one was very stiff, and the right one's a little bit more arthritic, but that left one, she's been very mobile for many years. Those are the ones actually you don't have to get too worried about doing a subtroch osteotomy, at least in my experience. You're going to be prepared for it, but many times you can get away without doing a subtrochanteric osteotomy because they already have a lot of motion. Now, it's the ones that have been operated 3 or 4 times. They've had a trochanteric advancement. They've had VRDO, other types of procedures. The problem with those is they tend to have a lot of scar, in which case those you really have to be more cautious about lengthening because the surrounding tissues are going to be encapsulated in scar. The neurovascular structures are going to be encapsulated in scar. It'll be a lot less tolerant to lengthening. So those I'd be very quick to do a subtrochanteric osteotomy. Anyway, so this is a case. So again, bilateral disease. In this case, she's been dealing with this leg length inequality for quite some time. I'm not too worried about trying to correct it all in one go. So the goal was to restore at least the most painful and stiffest hip first, which was her right side. And so in this case, proceeded just similar to the last case. You know, Interestingly, once I got an internal rotation view on the table, you can see how everything kind of falls back into place. So this serves as our sort of ipsilateral template for what we're trying to accomplish in terms of restoring leg length and offset. So this is the idea, is to put her back kind of where she was. Again, she's a little lateralized here, so I'm going to accept reducing some of that total offset. But again, I want to keep that femoral offset about the same. So again, putting going low, small, and medial. That's sort of the key. That's your mantra when you're doing a dysplastic case. Go small with your cup, go stay low, and go medial. And so by doing that, got pretty secure case. You could argue here I didn't need a graft because, again, center rotation is well medial here, but I went ahead and put a graft in like I did in that last case, and that's the result. And in this case, you can see that that side didn't have a whole lot of distorted anatomy. I could use a very straightforward primary stem for this, and get a very good result. And it wasn't that complex, a very straightforward case. Start to get on the left side, we have a lot more issues to deal with, and the again, neck cut under fluoro really helps. But reaming under fluoro, you're going to go low, small, and medial, and it's amazing how little bone you have down here and how distorted. But the use of X-ray really helps. Again, there's so many of these cases that I think I'm going to be able to get a 48 cup in, and you better be ready to go all the way down to 44 and even 42 for your cups, which means you're using 22 heads. So it gets pretty challenging to do these high dislocations. Um, you get the cup in place, put a few screws in. So we know I have a cup that's stable, and she was highly mobile. So in this case, prepping an SROM. Now, and why did I use an SROM here when I use a primary stem on the other side? An SROM here gives you a lot more rotational control. And as we know, when we're dealing with dysplastics and the more severe dysplasias, you're going to have torsional abnormalities that correspond on the femoral side. So she had well over 90 degrees of antetorsion, so being able to dial that back is an important part of the case. And so in this case, the SROM was a good implant to do that. And that's our final result with a 22 head. And again, no subtrochanteric osteotomy was needed. And here's our post-op results. And at 1 year, neurologically, no issue. Woke up fine, no issues there. So yeah, it's a very straightforward case using the anterior approach. But again, I've run into similar high dislocations where I've been forced to do a subtroch because it's just too much tension, and that's a intraoperative clinical decision that I make. And usually I just go for about 2 centimeter shortening, 2 to 3, and I just go with that, and that's been my solution there. I use a double oblique osteotomy for that, and sometimes I will dial off torsion by doing my first cut with the saw, and then fixing the rotation to the second cut with the saw parallel to the first cut. So you can take a wedge out that's of two different obliquities, but the final two components two femoral fragments come together and line up perfectly.
And one of the
You were going
things
to
you
ask me a
mentioned,
question? Sorry.
yeah, one of the things you mentioned up front was that she had quite a bit of flexibility on this left side before, certainly much more so than on her right side. How was her flexibility after this with the lengthening that you gave her and with the new hip center?
Well, she was pretty tight initially, and in fact, her IT band was quite irritable after surgery. We were able to get through that with PT, and somewhere around 3 to 6 months, she was feeling very good and feeling very even on the legs, and the flexibility was returning.
Yeah, and that was something did you talk to her about that ahead of time about how she might actually lose a little bit of flexibility up front or not so much?
I had no clue what was going to happen postoperatively in terms of the range of motion, but I knew she was painful, and I would expect that the pain was going to improve. It was hard to predict what her final range of motion was, but she remained very flexible, and so that's good. Um, these are some more cases. This one was probably one of the hardest cases that I tackled. Um, and I think it's because I didn't recognize preoperatively what the challenge was going to be. And this is a PAO that was done in our community, but it didn't go so well for the surgeon who was doing it. And it was a Perthes deformity. So these are really hard anyway. He tried to do a surgical dislocation with a trochanteric advancement and a PAO. And he had some challenges, but at the end of the day, I think she did a couple of years on this without too much problem, but it came time to convert. And so we went ahead and proceeded. And I think I did this in a staged manner by pulling hardware first, which was this, and then obtained intraoperative imaging and Then I proceeded with the total hip. And I think the thing I didn't recognize is on this image, you can really see it, is that the relationship of the walls. The red wall here is our anterior wall, and our green wall is our posterior wall. It doesn't leave a whole lot of posterior wall to support an acetabular component. And as I went in and I started reaming, I realized fairly quickly I didn't have much to work with behind this acetabular component. So ended up having to do what's called a medial protrusio technique, which is you kind of intentionally ream through the quadrilateral surface a little bit to put your cup in. And you can see I went about, 3 or 4 millimeters into the pelvis with my acetabular component intentionally in order to get stability. And it was a stressful case. I was really worried about whether or not I was going to get stability, but finally did, and I was able to do it without screws, and then proceeded with a Corai implant. But this is what it looks like post-operatively. And as you can see, that cup's medial to colar or the ilioischial line, depending on your definition. And the thing that's I didn't appreciate quite a bit is how much anterior column I was going to have to take, because this prior surgeon had retroverted so much. I had to take quite a bit of the anterior column away. That entire red area was removed in order to get clearance so that she could flex her hip. So it was a real, it was a daunting case. And you look at it in the pre-op, you go, it's not too bad. But if you don't understand the three-dimensional problem, then you can definitely bag yourself. And that's sort of this case.
But no acetabular fixation in this one.
You mean extra screws?
Yeah, no screw fixation.
I don't know. This was earlier in my career. I wasn't putting many screws in. I'll use screws more frequently. I think in my hands now, I probably wouldn't put screws in. This was, 10 years ago. So I was more bold then, I guess. So yeah, I went without screws on this one, but that was largely because of Joel's training. So this is a post-traumatic arthritis with intrapelvic hardware kind of case. So this is, an ideal indication for an anterior approach. And so this was my, using the Levine modification of the anterior approach, which is sort of the intrapelvic Smith-Peet. And so this surgeon had used a prior stop approach. It was done at our local trauma center. And, they did a pretty good job of getting fixation. And although I would argue that their reduction wasn't ideal, and as a consequence, the patient developed post-traumatic arthritis. So, yeah, going through, you could consider just doing this in a primary setting and cutting screws. But I think being facile with the intrapelvic anatomy extension, and I benefit from doing a lot of hip preservation work, doing the PAO. So this is a very handy approach for me because I do it all the time for the PAO. And so being facile with that is, I think, really helpful for anterior approach surgeons, because, there's cases where the ball will, the trial ball might sneak up along the psoas and end up in this space. There are other places where um, that exposure can be helpful, specifically anterior column deficiencies or revision work. So, I think it's a good thing for most surgeons to familiarize themselves with. But in this case, the screws come out pretty easily. And this is the view from my anesthesiologist looking down towards the knee. And so he's taking a picture. And so you can see pretty much everything you need to see. You can see the tensors being retracted by the retractor on the left. You can see the one at the top of the screen is just underneath rectus. And then you've got this lower retractor that's on the inside of the pelvis and the true pelvis, exposing the entire iliac fossa, which is giving us our exposure for our hardware removal. And the rest of the case proceeds very uneventfully. Now, this is probably more of the fracture work that I see these days. And I think the things that I've learned here are don't underestimate poor bone quality. Geriatric acetabular fractures are a pathologic fracture. They're not a acetabular fracture like we normally treat. So being able to understand that fixation is going to be challenging, I think that's an important sort of thing to comprehend when you're tackling these. So this is more of the common trauma that I see these days. I'm in a tertiary care center, and it's mostly geriatric trauma. Um, People fall down, and I get referred in. Typically, it's an anterior column or an anterior column posterior hemitransverse. So this is an anterior column pattern with quadrilateral involvement. It was an 82-year-old. She had like every medical condition. She sat on the ward of her hospital for 2 weeks before she even came to me, just trying to get medical clearance. She had renal insufficiency. And so when somebody comes in and they're a couple weeks out from this kind of injury, especially as they're older and they got bad bone quality, you can expect there's going to be head damage. So I don't even try to, fix them and wait and see. I just go ahead and proceed with a replacement. So this is what it looks like. And when you get your oblique views, you can see that the posterior column is largely intact. There might be a posterior hemitransverse component, but it's non-displaced. And here we have the head going with the anterior column. And so that's a classic pattern for an anterior column fracture. So understanding that and understanding the age and the typical pattern, I was like, all right, well, that intrapelvic Smith Peak becomes a really good workhorse again to get that reduction and help us get that acetabulum restored. So I proceed through that same approach using a small push plate on the anterior column, and then limited fixation is required. You got one screw all the way into the posterior inferior spine, one into the sciatic notch, and one going all the way down into the ischium. I have a separate screw with a washer dealing with that comminuted part of the anterior wall, and so this is what it looks like on the iliac oblique view, and then since we've got a femoral head there that we're going to do a total hip with, I took the head out, morsellized it, and impacted it. Now, when I impacted that, you can tell that I tested my fixation because you can see that we've lost a bit of our reduction. So I did a impaction grafting technique, but I in hindsight, I'd probably use a more robust fixation pattern. And what I do now is I typically use 4 or 5 screws, and I use a lot more of them. So that would be another little pearl that I've since switched to here is because you'll see, we put our cup in. I'm really happy. Looks good on these two views. And you can see where it is post-op, and I'm really happy. But you can see that we've lost our anterior column reduction a little bit, which means that our fixation is probably not strong enough to support full weight bearing. And her being 82 years old, you can't expect her to be partial weight bearing. And she shows up 6 weeks with a slightly increased abduction, increased anteversion. So the cup has gone into a bit of a hole. Um, so I watched this. By the time she came in 6 weeks, she was having no real pain. So I just said, all right, well, we'll keep an eye out. We'll see her at 3 months. And at 1 year follow up, it remains stable. And I would say that that cup is ingrown, but it's definitely, it was a little touch and go early on. And so the things I would say for a surgeon who's going to start tackling these kind of cases is, more robust fixation than what I applied here is probably important. And there are some really good plates now that provide quadrilateral surface buttressing as well as fixation all the way down to the pubic ramus. I would be, I would not hesitate to use that. That's what I do more commonly now. And these plates I think are made by Stryker if you're really wanting to find them out there. Yeah, and this is in post-op. And then, again, more complex cases, Perthes. This is a bilateral Perthes case. Again, when you're dealing with restoring anatomy on somebody who has bilateral disease, if you do it in a stage manner, you're going to end up with an interim period where people are going to be on one side quite long, on the other side off, and it can impair the rehabilitation and the early function. So, again, ideal case for a bilateral, approach. So
And
this is
what was the
go
age
ahead.
of this patient, Nick?
This patient was in his 40s when he presented with me, and his left side was largely the most symptomatic side, as you can see radiographically. That side's, bone on bone articulation. But since if I just did the left side, I would worry that his function on the right side would still be so poor that it would interfere with his rehabilitation potential, and probably we'd be proceeding within 3 months to do the other side. So in this case, a simultaneous procedure was sort of offered. So we can see we have dysplasia, we have a short femoral neck, Perthes deformity. So again, neck cut under fluoro, key for these complex deformities. Ream low, small, and medial on dysplasia, and low, small, and medial. And so with low, small, and medial, When we put that cup in, yeah, we have adequate coverage and don't need additional screw fixation. Um, and then on the femoral side, a low net cut facilitates putting in a component, and then we just roll over to the other side, do a contralateral overlay, and then we do the same thing on the other side. And so this patient was very happy with our final result here. Challenges with these are length. I don't think there was a harder case than a unilateral Perthes. I think the hardest problem in the unilateral Perthes is trying to decide where you're going to put the length. And some guys will say, I'll split the difference. And I've done that. And I've had patients happy because they're, even or they feel even. And then I have other people saying, you'll over lengthen me. And I've had some people say, you leave me short. So I don't have a good algorithm for this. The other challenge that you're going to run into is if you don't adequately like bump up their offset a little bit, you're going to have trochanteric impingement. And that's been a challenge sometimes on these. So we get, as you can see on that left side, he still has a bit of what we call the gear shift sign, which is sort of as you abduct, they have no abduction or maybe 10 degrees abduction. But if you flex them up and then abduct them, you can get nearly full abduction. So it's this wild thing where the trochanter's impinging. So yeah, these are challenging cases. But this guy was quite happy with his final result. I think he still had better range of motion after surgery than he had pre-surgical.
Yeah,
So I got
I
lucky
think
there.
your point of the the unilateral Perthes and the length is a really important one. I've always found that the more I'm potentially increasing the offset, the less I'm going to add to the length, and vice versa. If I'm doing a really minimal offset, that they can tolerate a bit more length, and so I do think there's a combination in there somewhere, right? That's probably correct for everybody, but it's hard to tell.
I think you're right, because I've seen patients done through a posterolateral approach who have wide, they've had a bunch of offset added, and their length hasn't been added much, but they feel overly long. Or I've had patients where they've lengthened quite a bit, but they used a standard offset and didn't adequately restore their offset, but the hip has functioned for many years and they didn't even notice the length issue. So yeah, I think you're right. I think there's a soft tissue sort of element here on these kind of chronic pediatric deformities that you just have to, you know, you have to have the art and be able to feel what the length and offset are, what's that doing to the tension of the soft tissues. Um, Intraocular fracture. So this is the most recent FUBAR. So this is one where I think, this is a case that has shifted my practice more recently. I'm doing a heck of a lot more cemented implants now. I think the data out there is showing us, that periprosthetic fracture has a really bad trajectory if it happens in the first 6 months after surgery. And I think if you can avoid that, in some cases, it's worthwhile. So, as a patient, they came in. She's young, 65-year-old, and she's very athletic, meaning she's a rower. But you can see she's got some osteopenia, and she's got pretty profound arthritis both sides. And I wanted to do a simultaneous procedure on this patient, but she elected to go staged. But by the time she shows up, I don't know if you can see this, but she's had a remarkable progression of her osteoporosis. This is where she was before, and this is where she is now. And this is like a year later. I was like, whoa. And yeah, so anyway, so I proceeded with in a stage manner. I used an uncemented implant, and this is a Harai similar implant, fully hydroxyapatite coated stem, traditional length with a collar. And in my hands, it's a great implant in the context of osteoporosis. These are good implants for, for bone if you're going to go uncemented. But even then, you can see at 6-week follow up, there's a little periosteal reaction at the distal stem tip. And so I was like, yeah, that was probably on the edge of what I should be doing in terms of uncemented fixation. And so I didn't recognize this. This is in hindsight. And you go back to all these, I mean, what could I have done differently? And I look at that, and I'm like, yeah, maybe that was a sign that I probably should have been cementing the other side, but I didn't. And this is how she showed up at 2 weeks after surgery as she fell down some stairs. So you look at this pattern and you go, it's not too bad. It's oblique, short spiral oblique pattern. It looks like there is a comminuted lateral portions, maybe 3 fragments. And if you can get it reduced down to 2 fragments, it's pretty straightforward. But I think you can't discount the contribution of bone quality here in making the ease of a case. Because if this patient had more normal bone quality, yeah, you get it down to 2 fragments and then just tease them together and put a clamp on it and get it done. But in this case, as we'll see, things didn't go as well as I'd hoped. So my surgical strategy: line it up on the HANA table under X-ray, put in a screw proximal distal, convert it to a simple pattern, which is a simple spiral oblique pattern. I was like, all right, great. And using, getting my stem out and then putting a ball tip guide wire in, lining it all up, getting my clamp on it, and then passing um, my flexible reamer down. You can see things are already starting to fall apart a little bit here as I'm passing my reamer. And I'm going, uh-oh. And then I go to place my Kurai revision stem, which is my workhorse for a lot of these. Um, as it goes through, unfortunately, right now at this point is when the foot slips out of the boot
Hmm.
intra. The
Oh.
leg goes flying to the floor in an uncontrolled manner right there.
Oh.
And so now I've converted a simple pattern into now a multi-fragmentary complex pattern. And I s I thank my DePuy guys who were there, and they're like, "Yeah, we can be ready." So they had the reclaim on backup. So once you get to this sort of scenario, the Kurai revision stem is just sort of the philosophy of straight stem in a cylindrical bowed femur, but it has to be able to support weight. It has to be a load sharing device. But in this case, we have to go to something that will actually span the area. So the reclaim is what we used. But placing a reclaim from the front when you've got a highly comminuted diaphysis can be pretty hard, because the position that you want to place your stem in, from the front, applies a bit of a varus load to the femur as you're trying to prep the femur. So keeping it reduced while you're prepping it is really hard. And so uh, had a bunch of struggles with that. You can see, whoop, this was not working. So life was getting pretty hellish at this point. And at this point, I had opened all the way the entire lateral, aspect of her femur. So at this point, I delivered the femur out through the lateral incision, prepped it separately, and then because this was not working, and then I just prepped it separately, and then I passed the stem from above. So thinking a little bit outside the box here gave me the strategy to prep that distal femur with the reamer. And so that was the solution here, was to just deliver it out, prep the lateral fragment, prep the distal fragment, and then reintroduce everything from above, which I was able to do. And you can see we tapped it in. And then because I was dealing with such a comminuted segment and it was already pretty low, and you can see how little fixation I have distally, I was like, I am not going to trust that as my entire construct. So I plated her from stem to stern, as you can see here, all through the anterior approach. And thankfully, she comes into my clinic at 6 weeks, and she's now ambulatory without assisted device. And here she is, I think, so far I think she's at 3 months right now. You can see there's still quite a paucity of proximal bone, but we've got good distal fixation. But that was one that definitely took years off of my life.
So let's
So
stick with that case for just a second, because I have some
yeah.
questions for you that are a little outside of the how did you fix it. Um, so on a table, foot comes out of the boot. It's known to happen. It's not common, but it can happen. Two questions about
Yeah.
that. One, what was your reaction as the foot comes out of the boot? And two, what was the reaction of the people you were operating with?
Well, my reaction was, well, I knew something bad had just happened because all of a sudden the leg, I use a drape that's not translucent. I use a full drape as opposed to some of my colleagues who use a shower curtain. So if you're using a shower curtain, you know what happened immediately. But for me, I didn't know exactly what had happened, but I knew something really bad had happened. My feeling was, oh God, I just destroyed the entire femur. And thankfully, when my circulator noticed the foot was down, I was like, oh, okay, well, let's put the foot in and then assess what we have in terms of a problem. And so we put the foot into the bracket and we applied a little tension, and then I could see what happened. And at that point, I knew I had a highly comminuted diaphysis. And thankfully, I noticed that the two cerclage cables that I put in at the initial index. So right when I go in, I put those two cerclage cables in, one proximal, one distal, just so we avoid propagation of fractures. There was no propagation beyond that cerclage wire. So I was like, thank God I had that in there. And so that was my first step. When I saw that, I was like, okay, I can make this still work. Um, and then I think the second thing was just trying to keep everybody else calm in the room. And I think one of the big things I've learned is got more to do with the soft science of life, which is communication. It doesn't help your team if you lose control. You know, I think one of the things that I learned, and it was a hard one battle, was the best thing I can do is as I feel my tension go up, is try to slow my reactions down and my speech down, and try to lower my tone of voice as opposed to going up, is try to bring it down an octave. And I don't know why, but it seems to keep everybody else calm. I don't know. I think it's something you practice throughout your career is your response to stress, and you get better at it with time.
And was your initial thought, all right, let's troubleshoot, let's problem solve, let's see what we need to do to get this back on track? Or does it go to other things like, how am I going to explain this to the family? What am I going to say to her? How am I going to change her post-operative course? Things like that. Where does your mind go? Or does it go every place all at
Oh,
once?
that's well, your mind goes a million places at once, and I'm blessed as I work in an environment with some great surgeons. I don't know if you know Robert Maley, Peter Callender. These are good guys in our area. They do a lot of anterior hips, and you know, I just took a moment. I just packed the wound. I did my survey with X-rays, packed the wound, and my dad used to do this. He was a trauma surgeon. He'd be in the middle of a both column acetabular fractures. Things are not going right, and he would pack the wound and go out and have a cigarette. He was terrible that way. He'd just go out and have a smoke. But he said you could come back after that smoke and you all of a sudden you'd see something different and it would go totally different. And so taking a pause and not trying to hurry through it. So I took a pause at that moment. I called Peter Callender, called Robert Maley, and I said, "Hey, you guys, I have this scenario that occurred, and you know, what are your thoughts here?" And Peter said, "Well, maybe just plate it from the outside first, and then see if you can reconstruct a cylinder." And Maley was like, "Yeah, just prep the distal femur and pot it, and then go from there. Build it all off the distal femur." And that's where the solution of delivering the femur out the lateral aspect of the wound came. Was like, well, I got to prep it somehow, and I can't seem to prep it from above, so I'll just prep it down here. And so that was the way to do it.
And you talked a little bit about the value of your rep. I think you said you was your DePuy reps, right? Who had kind of a
Yeah.
backup piece available for you. Is that something? Were you surprised by that? Is that something you expect? Is that something that that's a relationship you built over time, or was this a surprise that you were
This is,
just
yeah,
happy about?
definitely a relationship built over time. So I didn't mean to speak over you, but yes, it is a relationship that's built over time. And so these guys were working with me for many years. And when we do femoral work, we have a reclaim on backup. That's just one of those sort of rule book kind of things. And I don't check to make sure they have it every time because I used to when I was first starting, but now I just kind of assume they have it. And I was thankful, so incredibly thankful that they had it on backup and they were ready to go. So
A little bit more about some of the medical prep. So, are you checking routinely for bone mineral density, or are you doing anything for a workup of osteoporosis, things like that, ahead of time in patients that you might be suspicious of it? Or tell me a little bit about what you do in those scenarios.
well, I don't think a DEXA scan has really helped me, but when I look at a radiograph, I should look at that femur and I should see about a third cortex, a third is the medullary canal, and a third cortex if you divide it up. And in this case, it was like 2 millimeters of cortex with like 8 millimeters of medullary canal and two. So I knew I was going to be dealing with it. Um, that's sort of been my sort of take. If I don't see the typical third, I start to go, okay, there's some osteopenia here. And then I have a much lower threshold to do a cementation technique. And I think part of it was that I hated the cement tools, and I was trained using surgical simplex and an I-beam construct in my training. And I hated doing those through the front because torsional control was a little bit tricky, and the cement, getting good pressurization, getting good cement mantle was hard from the front because the nozzles and the pressurization tools were not designed for anterior approach. So it was never really facile in my hands. So I went away, and I went almost all uncemented for a lot of years. And then I think it was seeing Jonathan and some of these other guys using French paradox cementation technique kind of switched my mind about it. And actually, it was Lucas Anderson, who's in Utah, was one of my junior residents. Brilliant guy, just absolutely phenomenal surgeon, incredible hands. Yeah, he's just like doing this thing. He called it a French Express, where he assembles the entire stem on the back table and then cements it in, just taps it in, line to line. And man, it's facile, it's fast. You don't have to worry about, somebody accidentally bumping the leg and shifting the torsion of the stem, because it follows the path that you broached. And the cementation, I think, in the literature, starting to show that this sort of French paradox cementing technique seems to be viable for the long term. And that's kind of when I said, all right, this is sort of the technique that I'm going to start adopting for cementation. I've been very pleased with it.
Yeah. And you touched on this a little bit, but I do want to just kind of ask you, well, I don't want to betray anything, but you're close to do 2 decades in practice, a little under 2 decades in
Yeah.
practice, and this case was relatively recent. How do you think a younger Nick Mast would have dealt with this, and what advice would you want to give him if instead of calling those other guys, he called you?
Well, I think a younger Nick Mast would have done the same thing that I did. I probably would have called Joel. Yeah, Joel. Yeah, in fact, I know I did early in my career. I was calling Joel, and I think the biggest thing that I can encourage a young surgeon to is to develop mentors, relationships with senior surgeons who have been in the fold, been in the in the tough spots before you. And I think, and that's one of the great things about like AHF and um, these other, groups that kind of work together. You can develop those relationships. And, I have plenty of younger surgeons that I've met through AHF who they have my cell number, and they'll text me a interesting case or a complex case, and we'll talk about it. It's sort of my way of giving back, but it's also, I feel like I'm paying back for all the years that I leaned on, you know, all of my colleagues, probably including you. I think I showed you a few challenging cases in my career. So yeah, I think that's probably the thing, is to understand that no surgeon is completely alone. And I think the best thing to do is cultivate those relationships so that you have somebody to call upon when things aren't going right.
Well, Nick, I can't think of a better place to call it than there. And I really appreciate you being with us today for sharing these cases, both the victories and the trials and tribulations. And I really appreciate you joining me today on the AHF podcast.
Yeah, again, it's my service to the community. I had to go through my school of hard knocks, and if I can keep somebody else from having to do the same, that'd be great.
Well, thank you so much.
All right, take care, and thanks again.
Thank you for joining me for this episode of the AHF podcast. As always, please take a moment to like and subscribe so we can keep the lights on and keep sharing great content just like this. Please also drop any topic ideas or feedback in the comments below. You can find the AHF podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps. as well as in video form on YouTube /at Anterior Hip Foundation, all one word. Episodes of the AHF podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips happy, healthy, and maybe fracture-free.